Good morning, everyone. And before I introduce our lovely speaker, I just want to go through a couple announcements. First of all, my name is Deborah Namey, and I will be one of the facilitators today, as well as Heather Forbes, who's up front, and Jamie Baker, who will be in the back. So if you need anything, please let us know. Also, the exhibit hall is open today until 5 p.m. There will also be an amazing poster session with light refreshments and the Art of Expression exhibit from 3:30 to 5:30 in Dean's Hall, room 1 and 2. Also, the Children's Institute will be putting on their play tomorrow at 3 p.m. in room 108. That is a definite must-see if you have the time to go. It is incredible. Also, remember, in order to get continuing education credits, you must complete and hand in the verification form at the registration desk prior to departing on your last day of the conference. This is where you would put the codes in that we will be presenting at the end of the presentation. If you are an ASHA member who is watching remotely via webcast, the CEUs are not available through Penn State or Patton, but as an attendee of the webcast, you can print out a copy of your attendance certificate and submit the certificate to ASHA certification directly for contact maintenance hours. Remember that all the PowerPoints and handouts will be on the website as well as the Groupio app, so you can download those as well. Kathleen Piazza is a professor of pediatrics and director of the Pediatric Feeding Disorders Program at the University of Nebraska Medical Center in Omaha. She has previously directed similar programs at the Marcus Institute in Atlanta and at the Johns Hopkins University School of Medicine in Baltimore, Maryland. Dr. Piazza and her colleagues have examined various aspects of feeding behavior and have developed a series of interventions to address one of the most common health problems in children. Her research in this area has been among the most systematic in the field and has firmly established behavioral approaches as preferred methods for assessment and treatment. In her roles as clinical research and training director, Dr. Piazza has mentored many interns and fellows who have gone on to make significant contributions to the field. Dr. Piazza is also the former member of the editor of the Journal of the Applied Behavior Analysis. It is quite an honor to introduce Dr. Kathleen Piazza.
Thank you. Good morning. Thanks for coming today. I really appreciate it. I guess you guys know a little bit about me, so I'd like to know something about you. Who in the audience are parents? Okay, a couple parents. Behavior analysts? Okay. Speech therapists? All right, great. Teachers? All right. Physicians? Dietitians? All right, great. Anybody I missed? Any zebras? Yes? OT. Okay. Sorry about that. It's a little early for me. PT. Okay, great. Well, obviously it's a little bit of a mixed audience, and so that means it's a little bit more challenging for us. But we'll try to, blend in enough information, I hope, that will be useful for everybody. So as you know, the topic today of our conference is pediatric feeding disorders. How many of you had breakfast this morning? All right, good. A lot of breakfast eaters here. So for many of us, it's very difficult to imagine how a person could not eat at all, and not be interested in eating. We know that eating plays a major role in our biological functioning. We need to eat to just chug along during the day. But what is also significant is that feeding plays a very important role in our social development as well. Most of our major holidays, our religious holidays, birthdays, political events, what do we do during those celebrations? You probably drink, but I eat. We eat. And so a child who is interested in eating, who doesn't eat, not only has some challenges in terms of growth and weight and nutrition, but also is missing out on some very important socialization events. And in fact, oftentimes, good feeding behavior, nutrition, and growth are one of the ways that we assess how a child is developing, and also it's a way that we assess parents and how they perform as caregivers. We know that many children with autism spectrum disorders have feeding problems, and estimates suggest that between 30 and 80% of children with autism have feeding problems. And we also know that feeding problems, poor nutrition, inadequate caloric intake place the child at risk for learning, behavior, and health issues in the long term. And it would be unfortunate if our friends with autism spectrum disorder acquired additional learning, health, and behavior problems as a result of poor diet and nutrition, because we can remediate those nutritional and caloric deficits. Now, one of the challenges that we have often is to determine, well, is this really a problem? Okay, how many of you eat beets? Oh, wow, lots of beet eaters out there. Okay, I picked a bad food. All right, what are some foods that you don't eat? Liver. Ah, liver. Any liver eaters? My mom was a big liver eater. All right, why don't we eat liver? Is that a problem? Do we need to put you all in treatment right now? Probably not. If you're receiving adequate amounts of all of your macro and micronutrients, it's probably not problematic if you don't eat one or two foods in every food group, in fact. And so what we have to sort out or figure out is, when is someone's diet and nutrition problematic, okay? And so what we're going to do right now is we'll look at what typical, or the development of typical eating looks like over the age range, and we'll compare that to problematic feeding. Now, what I want you to remember is, as we go through each of these descriptors, we're not saying that every child develops a problem at every stage. What we're looking at is, if the child has problematic feeding at this age range, what is it going to look like, and how does it differ from typical eating? So we know that sucking is a reflex. We're born with the ability to suck. But what you may not know is that it improves with practice, okay? You can be good at sucking. It's really comforting to know, I think, at least for me. And so when babies are born, they're typically going to accept the breast and bottle fairly readily. Now, that doesn't mean that they won't have problems latching, or their suck might be discoordinated for a period of time, but it will improve with practice and with time. A baby who's developing a feeding problem at this point will show discoordinated suck, swallow, breathe. So you may see patterns like suck, 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 and then the child is breathing very heavily, or you'll see children who will suck pretty well for the first few minutes, and then they just sort of poop out, and the rest of the time they're having discoordinated sucking or very low strength sucking, and they're not getting very much out of the bottle or the breast. You may see babies who will feed primarily as they're falling asleep and when they're sleeping, and when they're alert and awake, don't feed as well. Most caregivers will introduce baby food around 4 to 6 months of age, and people have babies. All right, so you put the spoon of food in the baby's mouth. What does the baby do? First time you feed him. Yep, comes right back out. Why? Because that tongue thrust is what's developed strongly over these first few months, right? You need that tongue thrust movement to suck adequately from a bottle. So the first time you put food in an infant's mouth, it's very likely that that's the practice motion, right? That tongue is going to thrust right back out, and the food is going to come right back out. Should you panic? No, obviously not. Again, with practice, the baby's feeding pattern, that tongue is going to improve. It's going to be able to start moving from side to side and replace that forward and back motion with lateralization, being able to move that tongue and move the food from side to side. In some babies, however, what you'll see is that tongue thrust persists, and it may be accompanied by mouth closure, by head turns, and refusal to take that baby food to transition from liquids to solids. And for many of the kids that we see with very severe feeding problems, that tongue thrust will persist for a very, very long time. And we've seen teenagers at times that have persistent tongue thrust. Now, as children age or grow and develop, we gradually start increasing the texture of foods, right? You'll start to put meltable solids on the tray. You'll add some little mashed food. You may break things up into the food. And babies initially, when they get that textured food, what are they going to do? Yeah, they'll choke and gag. Surprise! What the heck is those? But as they become more aware and used to those textures in the foods, again, their tongue will start to move and they'll start to be able to manage that. And as the teeth erupt, and even before the teeth erupt, you'll see that munching pattern, that up and down motion. They'll use their tongue as well to try to mash the food. But as you continue to raise the texture, that chewing pattern, that rotary chew, the ability to move the food, or I'm going to use this word bolus, and that's the food or the liquid that's going into the mouth. They'll be able to move that bolus around from side to side so they can move the food over to the molars as they get them, and they can acquire that rotary chewing pattern that we see. What we see in children who are developing feeding problems at this point is that rotary chewing pattern doesn't emerge. Oftentimes they'll either pocket the higher textured food, they'll spit it out, or even more problematic is they'll swallow it without chewing. Now, as I think for the kids with autism spectrum disorders, to me, this is the trickiest time, around 18 months of age. Why? Why would that be problematic for kids with autism? Yes? Yep, that's about when you start to see the symptoms emerge, right? And in typically eating children, we often see what's called neophobia. And that is rejection of foods that they previously ate. So the child is eating beets very readily. Now all of a sudden you put beets in the child's mouth and the child's like, what's going on here? I don't want that. So that's a very typical developmental reaction to foods at that point in time. And so then we get into this sort of dilemma of, my child is rejecting foods. Is this problematic? Now, in typically eating children, if you put the food back in and you continue to persist, it's very likely that the child will begin eating those foods. And that neophobia will resolve to some extent. You may still see some of those sort of food-specific or context-specific problems. I don't want the sandwich cut that way. I want it cut the other way. But again, as long as those don't become a pattern and are not characterized by a very restricted range of foods, that should not be problematic. With the children with very severe food selectivity, we see these very inflexible food preferences. And when I say inflexible, it doesn't mean that they only eat hot dogs for the rest of their life, although that may be true. It may be that they'll eat hot dogs for 6 months, and then it becomes pizza, and then it becomes hamburger. But the range or the number of foods that they eat is very limited, and the nutritional content of those foods is also very limited. And these children will often not eat, even if they're, quote, hungry, if you don't serve them preferred food. So we have parents who tell us, my physician told me just don't feed him. When he gets hungry, he'll eat. And he went for 3 days without eating, and he was falling over on the floor, and I got so worried that I went ahead and gave him something I knew he would eat. And so that really will differentiate those children who have problematic feeding from those who just have that sort of stage of neophobia. Now, when children go to school, and I hear this a lot, somebody told me just wait, I won't treat the feeding problem, I'll wait till she goes to school. And then she'll, see what all the other kids eating, and then she'll begin to eat and expand her diet variety. Well, that would be great, except that we know that our friends with autism spectrum disorders often don't pay attention to what their peers are doing. And what their peers are doing and being like their peers is often not a reinforcer. So waiting may not be a great idea. It's probably not the case that if you wait, it will simply get better over time. And oftentimes we see children where their eating patterns are severely disrupted by a change in environment. So the family goes on vacation, or they leave the child at grandma's, and the child might stop eating altogether, which is very serious. And again, will not eat even when they're hungry, and can go days and days and days without eating at all. And so, again, these still may be a little bit tricky. It may be difficult to really figure out what's going on. And also, I think that we have to be sensitive to the fact that children with autism spectrum disorders have lots of needs, right? They may not speak. They may not interact. They may have some issues with learning. And so for a parent, those are very difficult decisions to make. In other words, you know, what do I place my priorities on? I can't do everything. And so it may be the case that, you know, I need to let the feeding go for a little while just to have a little bit of sanity at mealtime while I teach my child to, or potty train my child, or work on eye contact, or getting my child to talk or stay seated. And so some of the other things that we're going to look at in terms of when we have a problematic feeder is whether the child has weight loss. Children should almost always gain weight. They should never lose weight. Even children that are very obese, oftentimes the goal will be to have them grow into their weight. So if you have a child with weight loss that is very serious, if it's sustained for at least 3 months, obviously children will have periodic weight loss with illness, but if you see sustained weight loss, then that's something to be very concerned about. If the child's going to the emergency room regularly for dehydration, that's another one that should be a big red flag. Oftentimes, children who have inadequate intake will have inadequate fluid intake as well. And actually, inadequate fluid intake or dehydration will get you into trouble a lot faster or more immediately than malnutrition. Malnutrition has its effects over a longer period of time. But if you don't drink enough, then a simple cold or a flu will oftentimes put you in the hospital. So if you see the child is getting admitted for dehydration, that should be a big concern because it can really affect your organs, and you can go into organ failure. If you have supplemental feeding in the form of a nasogastric tube, which is a tube that we put in the nose, it goes right into the stomach to feed, a gastrostomy tube, which is a tube that goes right into the stomach, or a jejunostomy tube, which goes into the small bowel. Those tubes are meant as, in most cases, a bridge between an event like a surgery and the period at which the child will be an oral feeder. So unless the child has some long-term medical or physiological problem where he or she won't be able to eat, the tubes are meant to bridge that gap between when the child can't eat to when the child will eat. And so if the child has a nasogastric tube for more than 3 months, and usually at about that time, most physicians will switch the child over to a gastrostomy tube, but sometimes don't. But even if they have a what we call a G, a gastrostomy, or a J, jejunostomy tube, for 3 months or more, we really should start thinking about intervention, because we know that long-term use of supplemental feeding in the form of G or J or GJ tubes places the child at risk for a long-term feeding problem. And so we want to really try to get those tubes out as quickly as we can and get the child back to oral feeding. Now, one of the ways that we can understand whether growth is problematic is to look at what's called a growth curve. Who's seen these before? Okay. So somewhat familiar to most of you. Okay. So this is what I call the parental star chart, right? You go to the pediatrician, the pediatrician weighs and measures your child, okay? These are curves in which thousands and thousands of children were weighed and measured, and created these curves. They're normed, okay? So when you see, I'll use the, when you see this line here, which is what's called the 50th percentile, that means that the average child is going to be or plot on that line, and I'll talk a little bit more about that. If your child's height or weight is above the line, that means your child is bigger than average, and if your child is below that line, it means your child is going to be smaller than average. Okay, so where's the best place to be on the growth curve? Yeah? Average above, okay. Anybody else? What's that? Following your own curve. What does that mean? Well, some of us are small, and some of us are bigger, right? And if you're small, you're the winner. No, I'm just kidding. It just means you can fit on the airplane. You're right. It doesn't really matter where you are, right? Some of us are going to be big. Some of us are going to be small. Some of us are going to be average. What matters is if we do what's called grow along our own curve. So what does that mean? Oh, these points moved. What? They moved. Anyway, sorry, a little malfunction on our growth curve. All right, so theoretically, imagine, I don't know why this happened. This is the 50th percentile, and this is the child's age. So what happens is the pediatrician will weigh the child. This is, in fact, the weight for age growth chart. So the physician weighs the child, and then he plots the child's weight by the child's age. And in a typical growth chart, the child should plot along the same curve throughout life, for the most part, without huge deviations. So theoretically, this child would always plot, let's say if we were going to say this is the final point on the 50th percentile, the child would always plot here on the 50th percentile. And why do we do that? We do that because everybody doesn't grow and gain weight at the same rate. And so what we're trying to see is the child growing at an appropriate rate? Okay, so if you looked at my growth curve when I was a child, I would have been right here. And I would always be right here, and I still am. Probably if you looked at my husband's growth curve, because he's a very tall man, he would have been right here. Yes? Oh, you can't see my, oh, duh. Thank you. It's the mouse, okay. I have moving data points. Okay, so here we go. All right, so let's, no, oh, fabulous. Okay, well, let's see. What we'll do is, I lost my pointer my last workshop. Okay, let's just imagine. See, this is the disadvantage of being short. I'll fit on the plane later, but I'm very short. Okay, if we look at this last line on this this chart, the very bottom one. Okay, see how it curves around like that? You imagine when my mother took me to the pediatrician, my red dots would have always been on that bottom line, right? Because I'm tiny. And my aunt was horrified and thought my mother should do something, but obviously she didn't. So I stayed tiny on that bottom line, right? Okay. And that's what you should look like. That's what a child's growth curve should look like. It should stay about on the same line, on the same curve. And that tells you that the child is gaining weight and growing as expected. So if I start off on that low line, that low percentile, I should be gaining weight or growing like other children who are small like me. Okay. By contrast, growth should not look like this, which is where you can see in this plot that the red dot starts on that very top line. So the child comes out or is born very early on, a big kid. This is a big, big kid. God bless his mother for having birthed this child. And then you can see at that second dot, that second red dot, that second measurement, now that child has come from the 90th percentile, big kid, to the 50th percentile, okay? Meaning now the child's growing more like on average. Okay, that's, well, he hasn't actually crossed. He hasn't crossed two growth curves yet. Okay, so then on that third line, Now he's below average in growth. See that third line is underneath that heavy middle line. And by this fourth point, he's all the way down at the bottom. That's a very, very serious problem. Now, why I show you this is obviously a very dramatic growth curve. But one of the things that you need to remember is children who are what they call falling off the growth curve may not be losing weight. Okay, this is the sort of take-home point. This child may just not be gaining weight as expected. So oftentimes parents won't be quite clued in to the fact that there's a problem because the child is gaining weight, albeit very slowly. And so I have lots of parents who come to clinic and say, well, you know, he's always just gained weight slowly, or he's gained weight slowly for a long time, and maybe don't feel like the failure to gain weight is problematic. But if you're seeing that falling off of the growth curve for a long period of time, that is something to be concerned about. Now, keeping in mind that in the first 2 years of life, growth can be somewhat unpredictable, but you should still be looking at those curves and looking at that rate of weight gain. And all of those factors that I've just showed you are ones to take very, very seriously. Now, it would be great, I don't know if it would be great, but it would be a lot easier for us if every child with a feeding disorder didn't have good growth, because then it would be like a light bulb and we could go, aha, you know, that's the child with the problem. But in fact, that's not the case. And oftentimes with kids with autism spectrum disorder, they actually grow just fine. If you eat enough McDonald's French fries, you seem to do okay on the growth curve. And so we have to start looking at other predictors of problematic feeding. And so when we looked at the literature, you know, there actually are a number of studies that compare the feeding behavior of typically eating children with that of different diagnostic groups like cystic fibrosis and other kinds of children. And lo and behold, those of you with children will not be surprised that typically eating children have behavior problems at meals. Imagine that. They cry and they tantrum and they refuse food. And so those measures aren't always the most sensitive to whether or not the child has a feeding problem. And it's actually meal length, which will differentiate the problematic from more typical feeders. And we find that meal lengths over 30 minutes are usually relatively predictive of a feeding problem. And so, you know, when you're evaluating children, one of the things that we always look at is how long does it take mom or dad to feed this child. And that can be indicative of poor oral motor skills, low appetite, a lot of different factors that may affect whether the child has problematic feeding. And it may be, again, that the child is growing fine, but mom's spending 9 hours a day trying to get calories into this child. Now, one of the challenges I think that we have as we're thinking about embarking on treatment is to kind of know what to do next, all right? One of the things that we want to keep in mind is that we never want to implement treatment with a child who may have medical or oral motor causes to their feeding problem, okay? And why is that? Any guesses? So if the child's having some sort of medical problem that's causing her not to eat, why might that be the case? What might be happening? She's eating, and then what's happening? She could be aspirating. That would be really bad. She could be having reflux, which would be causing pain. And so if we feed a child like that, we're probably just going to worsen the problem, right? Because the medical problem or whatever's causing the feeding disorder is not resolved. And so we want to ensure that any underlying problems, that we resolve any underlying problems before we embark on any kind of aggressive feeding. And so the dilemma is, you know, who do we have evaluated? Because probably not 100% of children in the world need to be poked, prodded, scoped. And so I always talk about, thinking about whether each child needs a comprehensive evaluation. And so let's look at, a lot of times people will say to me, oh, well, this child has a behavioral feeding problem, or that child has a sensory feeding problem, or that's a medical feeding problem. So we're going to use our great skills of, diagnosis and figure out what kind of feeding problem each of these children have. So this is a 13-month-old ex-preemie. He has a nasogastric tube, but he's pulled it out for this video. And this is the mom trying to get him to eat. So when kids come to our clinic, we have the parents feed the child. Thank you. And, okay. And we say, I want you to try to feed your child just like you do at home. We want to see what's going on. And so this is, again, our 13-month-old. So your job, okay, is to figure out whether the child has a medical feeding problem, whether it's oral motor, or whether it's behavioral. All right. Now remember your job. You have to figure out or tell me whether it's a medical, oral motor, or behavioral feeding problem. This is our 5-year-old with autism spectrum disorder. She eats one kind of food. It's a blended food with 3 or 4 ingredients. It has to have those 3 or 4 ingredients. It has to be blended. She won't eat anything else, and she won't eat the foods if they're separated. This is her mom feeding her her favorite foods. All right, imagine doing that 5 times a day. All right, this is our, 10-year-old with autism spectrum disorder. He has a gastrostomy tube, and most of his calories come from the gastrostomy tube. This is actually a staff member, feeding him in a systematic assessment that we're doing. So, all right, now comes the quiz. They probably told you there wasn't going to be one. All right, so remember, this is our little 13-month-old who thinks the child has a medical problem. Or a medical etiology, let's call it. Okay, are a few of you. What about oral motor? No takers on that one. Okay, behavior. Okay, now some of you are not raising your hands. You will be docked points. All right, so this is our little 5-year-old who thinks medical problem. Nobody. Oral motor. Behavior. Okay, we have a few more voters that time. All right, and our 10-year-old, who medical? No. Oral motor? All right. Behavior? All right. What's that? I'd like to pick 2. Oh, okay. Good, you win the prize. Okay, I'm sorry. That was like a little bit of a trick quiz. Because in fact, for all 3 of these children, it's probably the case that there were combined causes to, I knew that all along, to their feeding problems. And it's sometimes surprising that when we feed kids who have low oral intake or show these really significant behavior problems at meals, we often find as we, for example, increase intake or add variety, medical problems like vomiting or food allergy will emerge. Very frequently, I think very underestimated, is oral motor deficits. I always say that that's, I think, a big thing that people miss. We assume that the kid is 5 and they can chew or that they have adequate oral motor skills. And oftentimes, they need quite a bit of support from that standpoint to really eat, because for probably lots of reasons, but one of those is just simply practice. They're not getting appropriate practice. They have deficits in their oral motor skills. Okay.
Is that all you need?
Yeah. Thanks. Okay. So I think one of the things to really think about very carefully is, what is your due diligence when you're going to start intervening? And, you can do a complete workup, or you can sort of start small and keep going. I think at a minimum, your due diligence is to call the child's physician, primary physician, and talk about what you're going to do and discuss whether there might be any physical or physiological problems that might be contributing to the child's feeding problem. If the child has specialists, they have lung disease or heart disease, then for sure you should be talking to those specialists. I think if you're not qualified or don't have a lot of training in evaluating oral motor skills, then you absolutely should have the child do some sort of evaluation for swallowing to ensure that the child is a safe oral feeder. You certainly don't want to be feeding a child that's aspirating, where there's solids or liquids going into the airway. That's very dangerous, can cause pneumonia and even death or choking. And oftentimes, we don't have the training to assess the child's nutritional needs. And so sometimes having them see a dietitian might be indicated. And parents often, this is a very, very challenging problem. And so having some support on hand for the family is probably a good idea as well. And so, those are the kinds of things that you should be thinking about. And one of the reasons is we know from large studies or large-scale studies of children who attend feeding and swallowing or feeding and growth clinics that about 60% of those children will have a diagnosed medical problem. So a large number of children who have feeding problems are going to have concomitant medical problems, and the most common one is gastroesophageal reflux disease. And so you can imagine if you're a little guy and you're eating, and every time you eat, this acidic stuff comes up into your esophagus and it burns and it hurts, you might not be too jazzed about eating. And so if that's continuing as you're feeding the child, then you probably won't be a very popular person. So it's very important to consider that, and also things like allergy. You sure don't want to be in a feeding situation with a child who goes into anaphylactic shock, where their lips are swelling and then they can't breathe anymore. That's very, very dangerous. Oftentimes we are not trained as dietitians, so we don't know what the calories that the child needs or the nutrients. I will say that there is a really great website that you can go to. It's www.choosemyplate.com. It's on the CDC. It's a part of the CDC. I'm not encouraging people to act like dietitians. If you need professional support, you should get it. But if you just want to get an idea of the calorie range for a child and the nutrition range for the child, it will allow you to put in the child's age and activity level and sex, and it will give you a calorie estimate, and it will give you portion sizes, which I think is really great and really helpful for parents to give them handouts that say, your child needs, 4 cups of this, and this is what a cup is. So it's a really nice resource, and then it'll give you, like I said, some calorie values at each age range. And actually, if you go to this page, you can click on the calorie value, and the portion sizes will pop up. So that's kind of a cool thing for you to access. And just to sort of make a point, we did a study on kids with autism spectrum disorder that came into our clinic with feeding problems and assessed their nutritional content of their diet. And we found that all of the kids had significant deficits in macro and micronutrients. This is just an example of a child that came in, folate level. At the initial eval, you can see it's very, very low. There's a period of time between the initial eval and the admission, and it stayed low. And so one of the goals of our admission was to address the child's nutritional needs, so we made sure that at least a few of the foods that we included in her diet had folate. Like I said earlier, one of the big, I'm always on this soapbox, is I think people really miss oral motor deficits in kids. And we know that about 40% of children who come to feeding and swallowing or feeding and growth clinics will have diagnosed oral motor deficits, but they're oftentimes missed. And I just think that sort of people take feeding skills sort of for granted, right? When you are sitting at the table with your family, are you like looking at their chewing? You're not watching what their mouth is doing. And so sometimes, people just aren't realizing that there's a problem there. And I'm just going to show you this video to illustrate. This is a little 5-year-old who, when he came to our clinic, he was underweight. He wasn't gaining weight at the appropriate rate. And they were feeding him regular textured food. Was cut up into pieces. But I want you to watch what this looked like.
Chew it, don't swallow. Keep chewing. Keep chewing. Chewing. All right, you can swallow.
Everybody's hair standing out up on the back of their necks. All right, what did we see? Look good? No. What's that? He doesn't lateralize. I talked about that earlier. So his tongue is not moving the bite over. How did you know that? Okay, because he's gagging. So, yep, he's trying to use his finger, right, because he knows he can't move it over. So the bite goes into his mouth, and what's the first thing that happens? He gags because he's not controlling it. It's the bite's going toward the pharynx without him controlling it. So he's gagging in response to that and bringing the bite presumably forward. What else did you see? Sucking it, right. That's a huge thing that we see is kids sucking on it, or oftentimes what they're doing is using their tongue and trying to push the bite up against the roof of their mouth. And I'll tell you why I think that happens in a minute. What else do we see? What does chewing look like? Good rotary chewing, strong? No, kind of munching, up and down, pretty weak. What else? Didn't have good lip closure. All right, good observations. Those are great. Okay, so here's a kid with pretty poor, and again, obviously we pick out the most dramatic section of the film just to illustrate the point, but pretty poor oral motor skills. So why do you think he wasn't gaining weight? He can't eat, or his chewing, his eating is not efficient. So in any given meal, he's probably not getting that many calories because, he's not able to masticate the bites very efficiently or effectively. Now, where does this tongue thing come from, do you think? Well, one, it's a sort of a holdover from what you see in infant patterns of feeding initially. You'll see that kind of suckling sort of behavior. But also we think that it occurs because oftentimes these kids eat a lot of cookies and crackers and chips. What do those kinds of foods have in common? They dissolve. That's right. They dissolve. And so, a lot of times folks will come in and say, oh, well, she really prefers crunchy. And I always go, and what that probably means is that I can put the bite in my mouth and I can look like I'm chewing, if you're not watching really carefully. But what I'm probably doing is just tonguing it, and it's dissolving with my tongue and through saliva. And one of the first things we tell parents when they come in and we see that is stop feeding those foods. And at that point, I'm the most popular person in the room because that's sort of an advancement for the child, and they feel like that's a step back. But from my standpoint, the child's practicing the wrong behavior. And you can dissolve a cookie or a cracker with your tongue, but you get a chicken nugget in your mouth, and you're not going to tongue the chicken nugget to pieces in most cases. And it's just practicing bad skills, and it makes it much harder for us to teach the child to chew. So right now, Caitlin Kirkwood is going to do the next portion. Caitlin is a student in our PhD program. She's entering her final year. She had some excellent training in her master's program with Melanie Bachmeyer at the University of North Carolina, Wilmington. And she's extraordinarily knowledgeable about feeding. And so thank you for helping me out today. Oh, you want to turn this off? Yes, turn this off.
Why was she waiting for him to swallow? At the third time, why was he waiting for him to swallow?
So we do additional mastication checks. So it could be that, and this was not a good example of this, but it could be that the child just needs a couple of extra seconds or 4 to 5 more chews on a bite before it's fully masticated. She did not provide the prompt or the instruction to swallow the bite until she could check and see that the bite was fully masticated and safe for the child to swallow.
I just had a quick question. Going back to that 30-minute length of a meal,
Yeah.
what age are we looking at when that is a concern?
I think I think you can think pretty much across the age ranges. Really, most kids are going to be able to feed within 20 to 30 minutes.
Okay.
I mean, it's not an absolute. So if you have a kid that has a little bit longer meals, but if that's combined with complaints from the caregiver or other worrisome signs.
Okay.
Yeah.
Before we go into the assessment or treatment, we want to make sure that we set individualized, observable, and measurable goals for each child. The goals can include increasing the oral intake, the variety, acceptance of bite, or even decreasing inappropriate mealtime behavior. So we got a really good example of that earlier. You'll notice in the examples above that each of the goal is extremely measurable. So for example, if a child is currently consuming 12 ounces of food per meal, and we have a goal to increase the oral intake by 50%, the new goal would be 24 ounces of food per meal. Adding in some additional mealtime structure is the first step in progressing towards treatment. Creating a predictable environment is always key. It's very important for any child, but even perhaps more important for a child that has a feeding disorder. We know that caregivers try many different things to get their child to eat, which leads to a really long history of the meal conditions and the situation changing from day to day or even from meal to meal. What we tend to see is that assessment and treatment progress more quickly when the conditions of the meal are more predictable for the child. The child knows exactly what to expect and what we expect when the child comes into the meal. Structuring the mealtime communicates those clear expectations to the child. So the child knows exactly the location of the meal, where it's going to take place, the length, how long the meal is going to take, the specific foods that are given, and who will be feeding the child. Perhaps more importantly, the child is going to have a clear idea of the types of food that we're going to be presenting and the amount of food as well. Finally, adding in that additional mealtime structure helps to establish a baseline from which to compare the effects of our systematic changes over the course of treatment. If we structure the meal by presenting bites or drinks according to a specific schedule, a specific start and stop time based on specific rules, and then again that same specific amount of food, we're more confident that the changes that we make during treatment are what's leading to the changes in the child's behavior and not some other variable. So here is a quick example of a day treatment schedule. In the example here, each of the highlighted portions depict a meal for the child. For this particular child who was severely underweight and had a gastrostomy tube, we scheduled 5 therapy meals throughout the day. Each of the meals lasts approximately 30 to 45 minutes, and we schedule 30 to 45-minute breaks in between each of those meal blocks. During the breaks, the children will play, socialize with other kids, take bathroom breaks, and then work on other skills as well if it's part of their programming. For the younger children, we do schedule a longer break in the middle of the day, so he or she can take a nap. We like to program in naps when possible to ensure that the child is well rested and to ensure that the child is set up for success. I wish this were my daily schedule with a nap in between. So across the day, the child will have alternating solid and liquid meals. And although we alternate, we base the specific schedules on the child's therapy goals. So for example, if a child comes in and he or she is already drinking formula, or he or she has enough milk and enough water and juice throughout the day, then our focus will only be on solids. Now, I know what you're thinking. Typical eaters like you and me, we consume both solids and liquids during a meal. You may take a couple bites of food, then you have a drink, finish up the next portion. But we alternate between solids and liquids for children with feeding disorders because they require different skills. Children who don't have experience eating or drinking need to practice these skills separately until they become very efficient eaters and drinkers. We then combine the solids and liquids into a big portion meal at the very end, once we've seen that the child displays these skills separately. At our clinic, caregivers typically identify between 8 and 16 foods to work on during treatment. Based on recommendations from a physician, an OT, or a speech and language pathologist, and extensive baseline observations, we determine what the most appropriate texture for the child is based on their oral motor skill level. However, if you are in a school or a home setting or a smaller clinic setting, it might be more feasible to focus on one food at a time. There isn't a magical number for how many foods we choose. We just like to choose from a couple of foods from each of the different food groups. We also use specific recipes for each child, and this is done to ensure that the food remains consistent during treatment and that changes in the brand of food or the recipe or food don't contribute to the changes in behavior. So as you saw earlier, we had one little gal who was not eating the food separately. Those 4 foods had to be done in combination. And we actually follow a similar manner in which we have set recipes for each child that we use throughout the admission. Here's an example, and it might seem a little bit cumbersome, but again, it's very important to make sure that we're always presenting the same foods. This is an example of a recipe for green beans. So we record the food name, the brand, the type, the food amount, and then the liquid type and amount that goes into it as well. So this particular recipe is a recipe for a pureed food. We prepare this exact recipe for the child every single time we go to prepare foods, and then we also train the caregivers on how to make this recipe. What we tend to see is that it helps with the transition back into the home setting after the parents are done with their admission in our clinic. So I'm just going to show you these additives very quickly, just so you know that they are available and they're available as additional options. We often use these additives and the specialty products within our recipes that we create. For example, the DuoCal increases the caloric density of the food and is often recommended for by dietitians if the child is underweight or has nutritional deficiencies as well. The Thick and Easy thickens the food, and we do this to ensure that the foods are not only the same texture, but they're of the same consistency as well. So for example, when you puree chicken and you puree oranges, you can get them down to the same puree texture, but the consistency of those 2 foods are going to be very different. The chicken's going to be a little bit grainier, and then the oranges are going to be a little watery, and then they're going to have a couple of strains in them still. So adding the Thick and Easy helps to ensure that the foods are also the same consistency. Just as a disclaimer, we always recommend and highly encourage all practitioners to consult with an SLP or an OT if the child displays any swallowing difficulties. So what we saw earlier with the 5-year-old who was gagging, we would consider that he probably has some swallowing difficulties as well, and we would recommend that the child be seen for an evaluation by an SLP or OT before going any further. And that child was. In our recipes, we also include formula, milk, or a high caloric drink for those additional calories. We often see that using the formula or milk in the purees helps to smooth out the purees to make sure that they're at the same texture. All right. So the textures that we use range from purees to size 4 bites. And these size 4 bites are actually about the size of 2 Starbursts stacked on top of each other. We often begin treatment with purees, even when the children come in eating table textured food during baseline observations. And there are a couple different reasons that we like to begin our treatment with purees. The first is to establish compliance within the mealtime setting, so to increase bite acceptance of novel food and to decrease that problematic behavior. In other cases, we also want to use purees to increase the caloric intake for the child. As you saw a second ago, we can add in high-calorie formulas, milk, other additives, and those are easier to add into the purees. Pureed foods are also easier to swallow. And so reducing the amount of work it takes to swallow a food or the response effort that's associated with eating is going to be very important for the initial compliance and for children specifically with poor oral motor skills. If the child has poor oral motor skills, we'll often just skip the wet ground and the ground textures, because what we tend to see is that children will just swallow those foods in the absence of any chewing, any lateralization, any tongue movement, or chewing at all. In these cases, we move right from purees to the table textured foods and work on strengthening the chewing skills. Then, as the child's oral motor skills develop, we continue to increase texture until the child is consuming an age-appropriate texture. In terms of utensils, we often use the rubber-coated baby spoons. We use these given the smooth surface and the shallow bowl of the spoon, which allows for easy deposit of the pureed food into the mouth. We use maroon spoons for that same exact reason. The surface is smooth, the bowl is shallow enough that the child could easily remove food from the spoon with minimal effort, which is going to be very important to establish that initial compliance of accepting bites. As you can see, the maroon spoons come in two sizes. We have the small maroon spoons and large maroon spoons. We'll often begin with the small maroon spoons and transition up to the large maroon spoons once we see that the child can appropriately handle the bolus, has appropriate lip closure on the small maroon spoons. And we like to use these in particular because it aids in the transition of not actually changing the utensil. The only things that's changing is the size of the bowl and the amount of food. In our clinic, we also use a utensil called a nook, which some caregivers use to help initiate toothbrushing in younger children. The nook is ideal for some of the specific procedures that we use, and this is really important, just giving the slender design of the brush and then the bristled head of the nook brush as well. For drinks, we use a cutout cup or a nosy cut cup. The cups are made of a softer, flexible plastic, which allows the feeder to squeeze the side of the cup to help facilitate liquid flow. The cutout on the cup prevents blocking the child's face or the nose. And then the cups also help to facilitate transition to a larger bolus and a larger cup without really having to change the actual cup type. The only thing that actually changes is the size and then the color of the cup as well. Our liquid sessions typically consist of the child's milk, formula, or water, whatever that liquid is that we're working on, a 10 cc syringe, these pink cutout cups to start, unless we have an older child with more advanced oral motor skills, we use a larger cup, and then a blender bottle. We use the blender bottle to ensure that the formula and the liquid are completely mixed together and to ensure, again, having that same consistency of the liquid across all sessions and all feeders. We might start with something really, really small, something as small as a 2 cc bolus. But then as the child is accepting the drinks with low rates of problem behavior and we're seeing that they're safe to have larger amounts, we'll gradually increase the amount that we put into the cup. As the child demonstrates this mastery at each step, we'll continue advancing until we reach about a 15 cc max. That is the maximum amount that these cups hold. And at that point, we switch over to a portion drink. So we may have a typical cup that just has an open top, and then we work on more age-appropriate portions closer to the amount that a child would actually consume during a meal. So as you can see, everything is done very systematically, and we wait until the child masters responding at each step before we increase what we're asking them to do. As previously mentioned, we present solids in a skill-appropriate texture, and we choose one food from each of the 4 food groups to rotate through during the meal, resulting in the presentation of 4 foods for each meal. So, for example, this child will have chicken, green beans, oatmeal, and grapes during their meal, and then we'll rotate through bites of each of these foods to ensure that the child is getting practice with food from each of the 4 food groups. And then this is just an example of squash at a puree texture. Now, within each of these 30 to 45-minute meals, the therapist conducts multiple 5-bite or 5-drink sessions. We usually have a 10-minute session cap, meaning that we end the session at 10 minutes, regardless of where the child is in the progression of the meal. And that means even if we don't end up presenting all 5 bites or all 5 drinks, we'll go ahead and end at the 10 minutes. We keep the session short because it's easier for the child to learn what we want him or her to do when we have numerous short sessions. So we're providing many learning opportunities that come one right after another, but they're not going to be over a very long period of time. And then in addition to that, the short sessions reduce the response effort of eating or drinking as well. And again, that's key in establishing that initial compliance. Now, again, there isn't anything magical about these 5-bite sessions or the 10-minute meal cap. We can determine, or you can determine the number of bites that you're presenting or how long the meal is to run based on whatever your target goal is or whatever your treatment is. So again, if you're in a school setting, for example, you may focus on one food at a time, and it may be that you run 10 sessions in a row, 10 bites of foods. 10 is just easier math for me, so that's why I chose that one. But again, you'll tailor whatever your presentation is and how long the meal is to your therapy or treatment goals. All right, so here's an example of what we call a baseline. We added a little bit of structure to the meal where we're presenting bites sequentially. And then this is a video where we don't have any consequences in place. It's just a baseline, so we're just seeing, okay, if we add a little bit of structure to the meal, are we going to see a change in the behavior that the child is engaging in? So clearly not interested.
Take your bite.
And this particular child once told me he had magical powers to get rid of all of the bites. So we had to test it out, of course. And then here's a quick clip of adding some structure as well. I apologize for the lack of sound on this video, but as you're watching it, I want you all to keep in mind just what you're seeing in the video. So what are some of those observations, and what are some of the potential effects of adding a little bit of structure to the mealtime? It's probably a good thing we don't have sound on this one. Okay, so what are some of the things that you guys are seeing during these 2 videos of adding in some additional structure? Yep. Anything else? Okay, so we are seeing a little bit of protesting from the 2 children. We're also seeing that the protesting is happening following these multiple opportunities for the child to take the bite. So I probably should have had that one a little bit longer, but what we saw is that the therapist was providing the child with multiple opportunities to take the drink. What we tend to see, as I previously mentioned, is that when we provide children with short, numerous opportunities, what we tend to see is that children respond a lot quicker to treatment. So yes, we could, which is kind of a different topic for another time, but in this example, adding structure can just be as simple as providing the child with more opportunities to have an appropriate mealtime response. And we saw that the little girl in the video did kind of lean forward to check it out, and then we saw immediately that she was very upset. She was not happy with what was in the cup. So just a little bit more about the structure. We select the type of seating based on the child's age, the child's body size, so specifically their height and weight, as well as the child's safety. So in our clinic, safety is the most important thing. And here we have numerous examples of the different seating that we can use for a child. We do have alternative seating that we use for older children. These are specific for some younger kids. We always seat the child in a 90-90-90 position, and the child's feet should always be supported on the ground. When we do use additional straps, the chest or the lap belt should always be secure, but not tight enough to cause any marks or leave any marks. We often use Velcro straps on the chest if the chest straps do not remain secure on the child throughout the session. And as we saw in one of the earlier videos, we saw that the child was able to successfully get out of the straps as she was avoiding the bite from mom. So adding a Velcro strap to the chest straps is a really simple and easy way to ensure that the child remains secure and safe throughout the session. Other materials that we use include additional seating for other team members, scales to make sure that we're always getting a pre and post weight so we can track exactly what the child is getting in, timers, toys when we're using them during treatment, and then a table that's appropriate for the child. So the younger children, we tend to just put in seats that have trays on them. But for older children, so from 5 and up, we may be more likely to have them seated at the table. The cleaning items are also located in the room and include biohazard bags and absorbent pads for vomiting, hand sanitizer, tissues, red wipes, paper towels for sanitation, and then, of course, gloves. You're lucky I didn't have a vomiting video. So here's just a quick example of what a session room looks like. And then as you can see, all the foods are prepared, the toys are there, and then we have age-appropriate seating for that child who is about to begin that session. All right, so switching gears really quickly, during any assessment, we always want to make sure that we're collecting data not only on the child's behavior, but also on feeder behavior. The child behavior might include acceptance, expulsions, whether the child swallowed or pocketed the bite, coughing, gagging, vomiting, inappropriate mealtime behavior, or those refusal behaviors that we observed earlier, and negative vocalizations or crying, screaming, some of those protests from the children. The feeder behavior also includes multiple components. So making sure that the feeder is placing the bite in the same position every single time when they're presenting bites, providing correct praise. We always want to make sure that we are delivering specific, appropriate praise when a child has a appropriate mealtime behavior, such as accepting bites or swallowing bites. And then also we want to make sure that the feeder isn't providing any additional attention for any inappropriate mealtime behavior that we see. So here's an example of acceptance and mouth clean.
Lettuce. Awesome. Good taking your bite. Yay,
Good job! Yay! Oh man, we got the
You got your light up shoes on? You making them go? Show me out. Yeah. Good swallowing your bite.
Great job.
You are a rock star. Hey, buddy.
All right, so in this example, you saw that the feeder placed the bite in front of the child, delivered a very simple, clear instruction, communicating exactly what we wanted the child to do, to take a bite. And then when the child accepted the bite, the feeder provided praise, good job taking your bite. The child swallowed the bite, and the feeder again provided praise, good job swallowing your bite. So this was just an example of making sure we always are providing specific praise for the appropriate mealtime behaviors that we see. That makes them more likely to happen again in the future. All right, and then here's another example of acceptance and mouth clean from our same little buddy from earlier.
Take your bite.
He lost them, they're gone.
Great work taking that bite. Nice job, bud. And great work swallowing so very fast.
No, Vivian. It's Vivian.
So this particular child, he always was so proud of himself whenever he was accepting and swallowing bites, and he came up with very creative nicknames for all of us. So now that we've seen some examples of appropriate mealtime behavior, accepting and swallowing bites, let's switch gears and look at a video that has a lot of inappropriate mealtime behavior. And what we're going to do is we're just going to take a little bit of data as well. So for this clip, I'd like everyone to take frequency data or count the number of times that we see inappropriate mealtime behavior. So that can include the child turning the head, covering the mouth, or pushing away bites. All right, you guys ready? Okay, so that was one bite presentation. Adding in structure requires multiple bite presentations, so you're going to see mom present another bite in a second. All right, bite 2. All right. So just on average, about how many counts of that inappropriate mealtime behavior did everyone get? And just shout them out. Okay. 17. Anything higher than 17? What did you have? 20. Okay. Anything else higher? 32. All right, we have a winner. So that's a really big range that we have here. Why do we think we might have such a wide range and a discrepancy between the number of inappropriate mealtime behaviors that we were counting? Okay. Ongoing. Okay, good. Yep, good. Okay, so that ties us into one of the most important aspects of data collection. Whenever we're collecting data, we want to ensure that we have concise, detailed definitions of a behavior, and this would include noting if there are multiple instances of a behavior, we want to make sure that we're coding, even if they're occurring at the same time. So really quickly, we're going to break into groups, and you can just turn to your neighbor. And what I'd like everyone to do is to create operational definitions of inappropriate mealtime behavior or refusal behavior that we might see during a mealtime. And so just as a reminder, we want to make sure that we have concise, simple, but also detailed definitions of the behaviors that we're wanting to observe. And I see it's like 9. Or sorry, 10 people. Okay. And then just as a reminder, after this exercise, we'll take a quick break. All right. So we'll give you a couple seconds to wrap up conversations, and then we're going to come back as a group, and I'm going to ask some people to go ahead and let me know what their definitions are. I don't know if we want to use the mic to go around. Oh, we should take a break now. Okay. Oh, I don't know. We can go ahead and take a break now. Yeah. Oh yeah, 10:30. Base submission, then take a break. Okay. Okay, sounds good. All right. Oops. Okay. So before we rewatch the video, we're going to recode that video based on the definitions we come up with. I was wondering if some people would be willing to volunteer their definitions to share with the group. And we have a mic that's coming around too. And there isn't a right or wrong. We're just kind of getting an idea of what people are seeing. Yeah, perfect. Thank you.
Okay, so we had the head turn, and we defined it by rotating the head away from the utensil, and then we defined it as ending when the child orients back to the utensil.
Okay, perfect. That's excellent. Other definitions that the group came up with?
We talked about, I feel like, a bunch of different ways to take data, but it seemed like it was almost continuous, so we thought maybe like a whole interval recording at first would be good, and then change it as the child gets better.
Okay, perfect. Yeah, that's a great. So, so we have a couple of specific definitions and then other ways of collecting behavior or collecting the data. Perfect.
We sort of did it in like 3 different ways, like doing gestures, protests, verbal protests, and facial movements.
Oh, perfect.
So if you had the child uses gestures to protest, such as pushing food away, arching back, shaking head, turning head away, all those would be lumped in one. Okay. And then verbally protesting by crying, whining, saying no, or then by exhibits facial movements like pursing the lips, biting on the spoon, that type of thing. So you would have, instead of hitting every one of the times she pushed away, you would do gestures, verbal, and then the pursing of the lips.
Perfect. Yeah, that's great. Any other last minute definitions we want to chat about? Okay, thank you guys so much for sharing. Those were excellent, and Deborah's getting on her steps for the day. So what we're going to do is we're going to rewatch that video based on the definitions that you as a group came up with, and then we're going to rescore and talk about some of the differences. Was it easier to see or to collect data on the videos, and what that means for us as practitioners as well. I like when she tries to say goodbye to the bite. She's like, see you later. Okay, so that was the first bite. That's going to be the first trial. And then we'll move on to the second one when the mom presents the next bite. All right, so let's get a new tally of how many instances of that problem behavior we saw this time when we had specific definitions for the behaviors we were looking at. All right, 1 to 5. Who had 1 to 5? Okay, 5 to 10. A couple people. 10 to 15. Okay, 15 to 20. Right, and then 20 to 25. Okay, anything over 25? Just a couple. Okay, good. So we were a little bit closer there as a group. So operational definitions, or having specific definitions for the behaviors that we're observing, they're key. So they allow us to observe behavior by what it looks like, and then we use those same operational definitions to help determine why the behavior is even occurring in the first place. So the definition that I have up there right now is just kind of what I had said in a basic manner to say, okay, these are the things we want to collect data on. And although this definition in red does not look concise, it is a complete definition. So this is one of our working definitions we use in our clinic, defining inappropriate mealtime behavior. The head turns almost have their own definition. So we say you're going to score each time the child turns his or her head when the middle of the mouth moves 45 degrees or 2.5 inches backward from its current position when a utensil, bite, or cup is present within the child's reach. So although it seems that it's a little bit cumbersome, it's very concise. We have a really good idea of what exactly 45 degrees is, and all the therapists are trained on this, because a head turn from midline to here may not be problematic, but a head turn more than 45 degrees away from the bite is going to be problematic for the feeder to deposit the bite. So that's just a quick example of what one of the operational definitions we use in our clinic is. A common concern among, oh, yes, it's 10:30. We'll go ahead and take a quick break, and then we'll come back to a little bit more data collection before switching gears to treatment. Sorry, I keep losing track of time.
Just a reminder, if you could be back here at 11:15, please. Thank you.
Sure. So a common concern among practitioners is that it isn't feasible to observe a behavior, take data, and implement a protocol all at the same time. I mean, just watching the behavior happen alone was really difficult to collect data on. But it's always possible to some extent to collect some data. What we tend to do is to start with one or two of the most important dependent variables. So if your goal that you're starting with is just acceptance of a bite, then that's the variable, that's the behavior that you're going to begin taking data on. Once you achieve that goal, you may see that you have some new behaviors emerge. So the child is now accepting the bites, but then the child's spitting out the bites. At that point, if you know acceptance is occurring reliably, then you can just switch over to taking data on expulsion or spitting out of the bite. And even if you don't collect data on a variable from the get-go, having some data once that behavior emerges is always better than having no data on it. In the exercise that we just did, we took frequency data. If frequency data isn't feasible, so for example, we had a range of 12 to 32 the very first time that we took data on the video, you can always switch to an occurrence, non-occurrence database system. So just yes or no in that trial, did you see any refusal behavior? Did you see inappropriate behavior? And then simple yes. The next trial you have, you might have a simple no. So this is just a quick example. You have the name of each food that you're working on, the bite number or presentation, and then the child behaviors of concern. As I mentioned, for example, if you are first focusing on acceptance, then acceptance would be the variable that you place here. Often what we see is that you'll take data on acceptance and inappropriate mealtime behavior, which is on the next slide. So simply, as you're going through it, you're just going to hit yes or no whether or not the child accepted the bite. and whether or not the child had inappropriate mealtime behavior. Once you see that the child is consistently accepting the bite, meaning that they're accepting bites 80% or more of the time, then we can either switch over to a more advanced behavior, such as, okay, now the child's accepting the bite, we're going to focus on swallowing the bite. Or if you see new behaviors emerge, such as spitting out the bite or packing the bite, you may want to take data on whether or not the child swallowed it, whether or not there are any gags, and then, of course, spitting the bite out or crying if we see crying emerge as well. So that simple occurrence, non-occurrence data is a very easy way to track some of the behaviors that you're observing during the mealtime. So here's another example of a sample data sheet. We have our yes or no down here. Did the child accept green beans, which is the first food on the first trial? Yes or no? And then did the child have inappropriate mealtime behavior? Yes or no? So in this example, the child did not have inappropriate mealtime behavior during the meal. You're going to mark no for this. But then you may see on future trials, you are going to see instances of inappropriate mealtime behavior, which can just be denoted by a Y for yes. All right, so that wraps up our data collection. Dr. Piazza is going to get into treatment. This is the good stuff.
Okay, thanks, Caitlin. So we've talked a lot about structure. I know that's not always the exciting. She got delegated to the more, what I call, boring part of the talk. But it's really, really important to have that structure, to have, to set up a situation where what you're going to do over and over and over again, and that's going to be the platform from which you establish treatment, okay? So you need to make sure that you have that structure in place, and you know what you're going to do going forward so that when you implement your treatment, you're going to know whether your treatment is effective or not. Now, what we're going to talk about today in terms of treatment is we're going to talk about feeding-based treatments. And so some of this, it's going to start to get a little bit more complex because I'm going to show you some graphs and talk about, it's not going to cooperate though, talk about some analyses, and and I'm going to show you some videos hopefully to also make it simple. So it's going to start to wax and wane in terms of the complexity. So if I lose you, just try to hang in there. If you're about to fall asleep, take a sip of coffee, and we'll try to get there together. So what I'm going to talk about is feeding, and the reason that I'm going to talk about this treatment is it's a way to think about intervention that you should be able to apply across a wide variety of children in a wide variety of situations. The downside is you're going to have to think. Sorry. So what I hope to do today is when you leave, you're not going to walk away with like a cookbook or a little package, which maybe is what you wanted, but what you're going to walk away with is a way to think about behavior that's going to help you develop treatments, again, for lots and lots of different kids. So feeding is just a way to identify what we call a starting point, okay? And then make very teeny tiny changes in behavior so that the child continues to behave appropriately, but you're changing things to move them toward appropriate eating. So let me give you a quick example. Any of you out there ever drank from your parents' liquor bottle? Oh, good. Sometimes I do this workshop and everybody goes, oh, no, we're perfect. We don't do that. Okay, so you do that. What's the goal when you, not just to drink, obviously, but you don't want what to happen? You don't want them to find out. So what do? Add water? Got some water adders? Yeah, good. Perfect. Okay, why do you add water? Right, so it looks the same, right? You want it to look the same. And so the parent behavior is look at the liquor bottle. Oh, it looks the same. Gee, everything is great. My child's not drinking, surely. So again, that's the same idea. You're making a change, but you don't want the individual to detect the change. Now, it's not trying to fool anybody, the goal of feeding. You're just trying to identify what I call a starting point. So the question you should always ask yourself, okay, this is important. If you're falling asleep, please wake up, is what will the child do? What does the child do, okay? And you have to really think about this. You may need to ask, you may need to do observations, you may need to talk to caregivers. Will the child sit at the table? Does he eat Oreos? Does he, lick things? Does he take medicine from a syringe? Now, I'm going to show you a number of examples of this, okay? But I don't want everybody to walk away saying, oh, we're going to do X. No. What you're going to learn again is the method in general, but the starting point is most important. What will the child do? Every child will do something. Sometimes it doesn't seem that way, but every child will do something, and so we find that starting point, and then our goal is to take that something and change it into what we want, okay? Take that something. Remember, what will the child do? And then how can we change that to get the child to do what we want the child to do, okay? We're going to make teeny tiny, gradual, systematic changes. The biggest mistake people make in feeding is they make changes unsystematically and they make them too big. So I'll often say, okay, what we're going to do with your child is X, and the parent says, oh, I've already done that before. And I totally believe that. But why we spent all that time on structure and data collection was that those pieces are really important to this. Okay, so what the heck am I talking about? So this is just an example of an analysis where we're looking at, again, that idea of what does the child do and what can we get the child to do. So this was a child that refused liquids from a cup. Okay, where's the, is it the, what button is for okay, done, now I see it. Oh, no, not that one, okay. Ah, thank you, right. It's the front one. Oh, no, I got it, okay. Okay, so this graph represents inappropriate mealtime behavior per minute, and those are head turning and batting, remember, just like you took data on before. All right, and so what we did here is we're trying to figure out why does this child not drink from a cup? And then the reverse question that these data are asking is, what does the child do? What can we get the child to do? Okay, so here we put liquids in the cup and we thicken them. That's this pinkish data path here. Okay, here we put liquids in a cup and they were just the regular consistency. Here we presented liquids on a spoon at the regular consistency. And then here in this red data path, these are thickened liquids on a spoon, okay? So we're presenting these different types of utensils and consistencies to the child to look at what does the child do when we present these. And the measure we're using is inappropriate mealtime behavior. So what you can see is, well, you tell me, okay, some of you may not be savvy about graphs, so you hang in there, and the rest of somebody else is going to tell us what you're seeing. Yes?
I think when you're putting your thick mixture in, you can see less and less objection.
Okay, yeah, so this is inappropriate behavior. Here's thick on a spoon. Okay, why is it not? There we go. Nope, I got it. It's the operator error. Okay, here's thick on a spoon, very low levels of inappropriate mealtime behavior. Here's thick in a cup. It comes down over time, but it starts out very high. Okay, what else? Yes? Perfect. So the cup, what does she mean by aversive? She means, that's a little word. That's what she's talking about, I think, because I'm, is that inappropriate mealtime behavior generally is higher when we present the liquids in the cup. Okay, that's this path. Higher inappropriate behavior, although it does go down here. So this tells us, aha, the problem is the cup. Perfect, very good. Okay, the problem is the cup. Okay, so now we ask ourselves, okay, what is the role of the consistency of the liquid? Okay, so the consistency is the thick versus thin. Okay, so we know cup is generally a culprit. And so then we look at spoon, and we see spoon thick seems fine. Spoon thin starts off high, but comes down. Okay, what would your starting point be? Spoon. Okay, we're in agreement on that. Would you do thick or thin? Thick. I probably would too. Good. Conservative ones in the group are doing thick. Now, the day that thin might be okay. And so if you wanted to be more aggressive, you could start with thin on the spoon. But you know that there was some initial high inappropriate behavior for the thin, and you also see very high levels in cup thin. So just to be conservative, I would start with spoon thin, okay? And so let's, and what would you do from there? Okay, so remember, let's think about this idea. Now we have our starting point. One thing I didn't mention, okay, let's look at this graph. What is on the spoon and in the cup? What do you think is in there? Formula, okay. A what? Whatever the drink is, right? And it's in all of them, or is there something different? All the same. And why is that important? Right, more than one variable. So we need to make sure that what the child is responding to, in other words, what the behavior, the level of behavior is in response to what we're presenting, whether it's the cup thick, the cup thin, and so forth, and not the flavor or something else about this manipulation. We need to make sure that everything else is the same. What else do we need to make sure is the same here? What else didn't we talk about? The structure, the environment. Yes. Right, so you're talking about how much is in the cup and how much is on the spoon needs to be exactly the same. Perfect. Okay. All right, so let's look at some specific examples of how we might do this from a practical standpoint, what that might look like. All right, so we just talked about an example of starting with thickened liquids on a spoon. In this example, we have a child that had a medical condition that required chemotherapy, but he didn't have cancer. And he had horrible refusal, probably because he'd been really sick. He had a G-tube, and when we started treatment, it was just very, very difficult. We interviewed the mom, talked to her a lot about what he would do, and she said, well, I actually did get him to take medicine from a syringe, okay? And so we thought, okay, well, we haven't made any progress thus far, so let's try this. So here's this brilliant idea of a syringe and a spoon, and we tape them together. Okay, very, very high tech. And so what happens here is we have very thinned out pureed food in this syringe. All right. Now, before we start this, what's the first thing we need to do before we ever start this? Before we ever tape a syringe to a spoon? Make sure. I think somebody said it, but maybe. Make sure he's safe to swallow, absolutely, especially with a syringe. What do we need to verify? That he'll accept food from a syringe, absolutely, because food is not medicine. And there's lots of different things, but there's lots of differences between them. So the first thing we do, okay, is we establish or show that he'll actually take food from a syringe, okay, before we start this, because we could do all this stuff for nothing if he won't take food from a syringe. Now, you can see this is a really tiny, tiny syringe. I think it's like a 2 cc syringe. And so we started off actually in this actual study of there was just a very microscopic amount of food in the syringe. And the reference for this is here. You'll have it in your packet. Okay, so these measurements represent the distance from the spoon lip to the spoon tip, to the syringe tip, I'm sorry. Spoon lip, or the edge of the spoon, to the edge of the syringe, 5 centimeters. And what we did is we just presented the syringe and the spoon together. We said, take a bite, and then we delivered the food into the mouth with the syringe, okay? So what we're sort of teaching the child is to accept food. And why did we tape the syringe to, or the spoon to the syringe? Syringe to the spoon. Right, we're pairing. Because this is the stimulus, the spoon is our end point, right? We want him to take food from the spoon. So we'd like it to be there from the get-go if we could. Now, if he refused to take the food from the syringe when it was taped to the spoon, we could have started just getting him to take it consistently from the syringe and then gradually try to fade in the spoon somehow in a different way. But fortunately for us, he actually accepted the food from the syringe. And so how did we decide whether to make a change? Arbitrarily? We asked that little guy who had the magical powers to decide. How did we decide? Yeah, we had criteria, and we had those criteria based on, what did Caitlin just spend? Based on the data, right? The data you're taking, all right? We took data on whether the child accepted the bite, whether he had inappropriate behavior, whether he spit it out, whether he swallowed it, and so on and so forth. And we had specific rules that said if the child accepted the bite so many times over such and such a period and had this low level of inappropriate behavior, there were very specific rules. Then we were going to move the spoon lip closer to the syringe tip, okay? So specific rules, specific data that we're taking that tells us, okay, everything is going fine, all right, the child is accepting, inappropriate behavior is low, the child is swallowing, and now we make a very slow, small, gradual, and systematic change. These aren't arbitrary, they're based on the child's performance or data, which is why it's so important for you to take those data. And when we present the syringe and the spoon, we're doing it under very systematic conditions, okay? There's a very specific protocol that we're following. Remember all that stuff that Caitlin talked to you about, figuring out how often you present the bite, how many bites you present, what the timing is, what the formula is or the recipe. All of those things, we figured all that out, okay? Because you don't want to start making a bunch of different changes here. You want to make sure that the child's responding to whatever systematic changes you're making, not arbitrary changes in, well, let's present 10 bites today, or, oh, he seems to be doing fine, so we'll do 20 bites today. Okay, we're going to be very systematic. And so each time the child reaches our criterion, you can see we untape it, and then we move the syringe closer, the syringe tip closer to the spoon lip. And we do that systematically from 3 to 2 to 1. You can see they're very close now. And then we then decided to move the syringe to the top. Through here, we had actually some difficulties where he was starting to have some refusal, and we started to make some manipulations to try to, again, move the spoon and the syringe closer and closer together. And the advantage of moving it to the top like this is that we could then deposit the food onto the spoon eventually. That was our goal. But when we moved it to the top, he started to have some problems. And so we then moved it to the side. I think I have the data. Yeah. Okay. So these are actually the data from the study, and I'll show you what I was talking about. Okay. So this is dependent variable is percentage of bites with mouth clean. Mouth clean is just a product measure of swallowing. All right, swallowing is difficult to measure. And so what we do, you saw this in some of the videos Caitlin showed, is we put the bite into the child's mouth, we wait for a short period of time, enough time that we think the child could swallow successfully, and we say, show me ah, and we look in the mouth. And if the child swallowed the bite, we score that as a mouth clean. If the child spits it out, obviously it's not a mouth clean. If the bite's still in the mouth, that's not a mouth clean. Okay, so we're talking about, again, a product measure of swallowing. All right, so here we show that, again, this is swallowing. This is with the spoon here. These data points represent the spoon. You can see he's never swallowing the bite. This is just the spoon by itself, okay, right here. This is actually 0.1 mils or cc's of food, right? 0.1. That's like a microscopic amount. And you can see actually initially he didn't swallow. And this is where we actually increase the amount in the syringe. Okay, so you didn't see that obviously in the photos because I didn't show it to you. Okay, here's where we start what you saw in the photos. So let's just take a quick look back. So remember, back. This is the 5 centimeter distance here. That's right here. Okay, so you can see he's swallowing very well when the spoon tip is 5 centimeters from the syringe lip, and then we move to 4 centimeters. Now this, what do you think that is? Anybody have any guesses? All right, feeding is a slow process, right? I mean, look at this. We had all these steps just to get him to take 1 meal of food. It's crazy. And so what we want to do is we want to ask the question, do we still need to do this, right? Do we have to keep chugging along at this turtle pace, or can we make a big jump? So this is a presentation of the food on the spoon, okay? That's food on the spoon. That's food on the spoon. That's our end point, our terminal goal. So what we want to do is we want to ask periodically, hey, can we just kind of move ahead? And so we present the food on the spoon to test that. And the answer is what? What's the answer here? Can we move to food on the spoon? No. Good. So we go back to our fading. 3, 2, 1. And you can see all along we're doing those tests. Can we jump ahead? No, no, no. And here's where I talked about the syringe is on the bottom. It's on the top. Here we put the spoon and the syringe in the mouth, and then, or we deliver the food from the syringe with them in the mouth, and then we have the syringes at the lip, and then we actually put the spoon in the mouth again. And you can see we have some drop off here. Well, it actually looks good. So we keep going, putting it in the mouth, putting it on the top, and so on. And then when we put it next to here, we put the syringe next to the spoon, you can see when we tested the spoon by itself, he starts taking it from the spoon by itself. So let's just go back really quickly. So you can see, oh, I keep going the wrong way. All right, so when we're at this point, we're depositing the food from the spoon, and the syringe is next to the spoon. Okay, that's the step. So now the food is on the spoon, but the syringe is still there. Then we probe. Remember those probes? We're just saying, can we just jump to the spoon by itself? And the answer is what? Yes, okay? So we took a kid who would take things from a syringe, and we progressed him to a child that would accept or take food from a spoon. Now, I don't want you to all run out and say, okay, let's buy a bunch of syringes. That's not the point. The point is we found a starting place, and then we made very slow and systematic changes to the stimulus. Okay, the stimulus is the syringe and the spoon, until the child was doing, he wouldn't do what we wanted, take food from a syringe in the beginning, and then at the end he did, but we use these very small and systematic changes. So you can see that as mouth clean stays at high levels, that's what we're doing. We're saying, okay, we're going to establish mouth clean at very high levels, and when they're at high levels, then we'll make that next change. And then periodically we ask the question, do we still need to do this? Okay? Now here's sort of a similar arrangement. You're going to think we love syringes, but actually we very rarely use them. So here's a kid again that we could get to take liquids from a syringe, but not from a cup. This was actually a little guy who had intestinal failure. He had less than 50 centimeters of small bowel. And when he came to us, he had a central line, kind of like a little port for intravenous feeds. And he was just so difficult during liquids that he was flailing and knocked his central line out, and there was blood everywhere, which, in case you were unclear, that's bad. And so we thought, well, you know, I think we have to regroup here. And so we, again, for whatever reason, the child would take the liquids from the syringe. And so we, again, that just very high-tech thing of taping, we like tape, the syringe to the cup. We call this the SPUP. No, that was when the spoon was there, not the syringe, actually. Okay, and again, same paradigm is the cup lip, the spoon tip is 5 centimeters, and we're using our data, okay, to gradually, really tiny changes, to move the cup lip to the syringe tip. 3 centimeters, 2 centimeters, 1 centimeter, 0.5. Now we're still depositing liquid from the syringe here. The lip of the cup and the syringe tip are flush right together. Then we decided that we would go ahead and put a hole in the bottom of the cup and put the syringe through it, which breaks my heart. I hate cutting these cutout cups because they're not cheap. And we deposited the liquid from the syringe. Then what we did was we deposited the liquid. It was right here. It was in the syringe, but we plunged the syringe and it went into the cup. And then we deposited it in the mouth, and then we backed the syringe out some more. Okay. Here's another example. We have a couple of papers on this blending or simultaneous presentation. And this is, I think this is the one I get the most feedback from families. Oh, we've tried that before, which, again, I totally believe. But it really is, for a lot of kids, an excellent way to introduce novel foods. And I've just given you a couple of examples of blends. So the key to this is to identify food that the child will willingly accept. Now, I always say that if the child has only one food that he or she will eat, I would not do this procedure. I just wouldn't risk messing that food up. You know, in other words, the child might stop eating that food, like even if it was Oreo cookies and that was all the child ate. If the child had 3 or 4 foods that he or she ate, then I would consider this. And so what we do is, it's exactly what it sounds like. We just simply put the preferred and non-preferred foods together, all right, in different ratios. So in this particular paper, we started out with, we identified foods the child would accept. These are a couple of children in this study. And we mixed them together actually in what we call a 90-10 blend. So I'll just show you what I mean. In this example, yogurt is the preferred food. So this is what the child will eat readily. And the target food in this example is green beans. And so in this picture, 80% of the mixture or of the food in the bowl is yogurt, and 20% is green beans. It's a yogurt, a green bean yogurt, which we're going to market soon, coming to a store. For most of the kids in this study, we started at a 90-10 blend, but I just wanted to give you some examples here. So 90% of the bowl was yogurt, and 10% was green beans. And then again, we make those small systematic changes. In the paper, we went from 80-20 to 70-30 to 60-40, and so on. This is 10-90 or 20-80. This is 20-80 here. So 20% of the bowl is now green beans, and 80% is yogurt. But again, we're making these small systematic changes based on the levels of the child's, whatever the target behavior is at the time. And I wanted to say something, but I can't remember. What you can do is, and this is a good sort of technique to have just in your pocket for lots of different things, is we'll usually do what's called a paired stimulus preference assessment. At the back of the packet, there's a bunch of references, and the reference for this paper is by Fisher and colleagues. Is there, if you're interested. And all it involves is simply identifying either, you can do it with toys, you can do it with food. In this case, I'm showing you food. And you're taking a number of foods, 16 or 20, and you're presenting them to the child in pairs. This is pudding, this is green beans, pick one. Okay, and you're presenting all possible pairs to the child, and it allows you to develop or graph a hierarchy of preferences. So this is pudding. The child selected the pudding most often, so that's HP means high preference. And green beans was the food the child never selected, so this is the low preference food, and then this shows you his or her preferences beyond the pudding. So you can identify the most highly preferred food and also the least preferred food. And I'll show you a little bit of data on blending here. So again, percentage of mouth clean is what we're looking at. Remember, that's that product measure of swallowing. After the bite enters the mouth, we're just looking into the mouth and seeing whether the child swallowed or not. The baseline, okay, this is all that structure that Caitlin talked about in this particular study. Each of these data points represents 5 presentations of the target food. We presented the bites about once every 30 seconds. Remember all that structure. If the child accepted the bite, the feeder said good job. If the child had a mouth clean, the feeder said good job. And we targeted 4 foods: waffle, green bean, peaches, and yogurt. You can see that in the baseline for waffles, the child never swallowed, right? Here's that 90-10 blend, so 90% of the bowl is pudding and 10% is waffles. Here we test out the waffles, 100% waffles. Remember, we're always asking that question, can we jump ahead or do we need to keep doing this kind of slow process? Can we jump ahead here? Can we just present waffles? No. Mouth clean is 0, so we go to that 80-20 blend. All right, 80% of the bowl is pudding, 20% waffles. Again, we probe. Now here, let's look at this. This is 60% waffles, 40% pudding. The child swallows just fine. Now we go to 50-50, so 50% of the bowl that's the probe, that's the 50-50. 50% of the bowl is waffles, 50% is pudding. What happens? Child stops swallowing, right? Do we panic? No, okay, good. I was worried. What do we do? Go back. Wow, you guys are smart. Okay, we go back to where we were successful. Again, another big mistake that people make in feeding is we hit a roadblock and we panic. No, we simply go back to where we were successful, and sometimes you have to go back and back. But you keep going back until you find a successful point, and then you go forward again. So here we go to 60-40, and we go back to 50-50, and actually the first point was 0, but then the child began swallowing at 50-50. And then we started the intervention for green beans. Now, when we start intervention for green beans, what do we see for peaches and yogurt? There's no intervention. These lines represent when we start the intervention, which is the blending. And what happens with peaches? You start swallowing the peaches without intervention. So this represents an increase in swallowing for peaches and an increase in well, he actually was eating the yogurt before, so that was really no gain there. All right, so it looks like we're getting what's called carryover. So the child's successful with the blending for waffles and green beans, and presumably as a result, we get some bang for our buck with peaches, which is really great. Okay, now let me just show you one more thing here. So here we're at 60-40 for green bean, all right? So again, 60% of the bowl is pudding, 40% green bean, and these are our probes. This is 100% green beans, and what happens here? He starts swallowing the green beans. Okay, remember, the diamonds represent 100% green beans, and remember, after each fading step, we're testing 100% green beans. So here, test here, test here, test here. He failed this one, so we didn't do any tests. Then when we tested here, look at that. We only got to the 60-40 blend, but then we could present the green beans by themselves. Yes?
So for this example and then the examples that you gave with the syringe, I see that there was success after, say, 160 sessions.
Yeah.
But I was just wondering how many trials per day are you running?
So each of these data points represents 5 presentations. So they're very, very brief. I mean, it's not, like Caitlin said, it's not a lot of presentations in any one, what we call session. So that's what we would call a session, which are 5 presentations. So you're doing it over and over and over again, but in small little chunks. So the basic sort of what I like to say is you're telling the child, hey, this is easy. You can do this. It's just, 5 and out. Little break, 5 and out. Little break, 5 and out. And we might do 11, how many in a 45-minute block? 6 to 15 sessions in a 45-minute block. So 45-minute block would be about typical for us, and depending on how good your therapists are, how efficient, and how cooperative the child is. You could do 6 to 15. You could do the math. I will not do math in my head, particularly not in public. It's just embarrassing. All right. So again, the idea is not, oh, run out and do blending, run out and buy a lot of syringes. The idea is let's find a starting point. And again, we're doing those demonstrations. Okay, here's just another example of that sort of demonstration. I showed you a preference assessment. Here's inappropriate behavior per minute. So we present applesauce, and then we present the other non-preferred foods, the healthy foods we want the child to eat. And you can see inappropriate behavior is at 0 for applesauce, which says, hey, this might be a good starting food. This might be a good place to start. I'm going to show you a couple of other examples, and I'll show you some videos, and then I'm going to leave time for some questions. Here's another kind of variation on that theme. Have a little child. This is a little guy, 5 years old, one of twin boys with autism. Mom had 5 kids. She homeschooled them. God bless her. It was amazing. And it came in with very severe food refusal. One of them had, this is the child with the G tube. The other one was just very severely selective. And we had a really hard time getting him to drink from a cup again. So she said, oh, he'll always drink water. Okay, and he needed calories because he was very underweight, even though he had a tube. Again, percentage of trials. A trial is just one of those presentations, like here, take this. Percentage of trials with mouth clean, remember our product measure of swallowing. So we wanted him to drink a pretty calorically dense beverage, or a drink with lots of calories in it. A lot of times what we see with the kids we see is they don't tolerate a lot of volume all at once. You try to put a lot in and they give it to you back. No, thank you, I'm trying to cut back. So we try, sometimes, as Caitlin talked about earlier, a lot of times we're trying to get as much bang for our buck as we can in the volume we present. So for this little guy, we wanted to present, this CIB is an acronym for a Carnation Instant Breakfast, which is what it was called back in the day. Now apparently it's Carnation Breakfast Essentials. That, I guess, is more hip. Okay, so this is what we wanted him to drink, okay? Milk with Carnation Instant Breakfast. It's a packet. 8 ounces of milk, you put the packet in the 8 ounces of milk. Obviously not swallowing it. Now, Mom says he presents water, so we say, okay, well, let's see if we can get him to swallow the water with the Carnation Instant Breakfast, and he doesn't swallow that. So remember, the squares represent the milk with Carnation, and the triangles represent the water with Carnation, okay? Again, here we want to make sure we demonstrate that he actually will take water from us because, you know, a lot of these kids, you know, if you change anything about how you present, you know, their preferred food or drink, sometimes they'll stop taking it all together. And I'll show you a little guy that looks like that in a few minutes. And so always test, you know, that hypothesis. We can't just go, oh, well, you know, Mom said he'll take it. That may be true, but maybe not from you or in some other situation. All right, our structured assessment, again, each of these data points represents 5 presentations of the drink, of whatever it is we're presenting. So we show he takes water. We're going to test again. Does he remember the squares? Milk with Carnation, triangles, water with Carnation. All right, no and no. Here we go back to the water. Make sure he swallows it after these experiences of not drinking the milk and the water with Carnation. And then we add 5% of the package of Carnation to 8 ounces of water. All right? So we have a little scale, we have a little cup, pour it in, so you get 5% of the package. It's very tedious. So he swallows that blend, so we go get back. Remember, milk with Carnation, water with Carnation, he's not drinking it. We go to 10% of the package, test the milk and the water with Carnation, no. We go to 20% of the package of Carnation and water. We go back to the probe, no. Oh, we go to the 30. He stops drinking. Ah, dang. So what do? We go back to 20%, fine. We test the, again, terminal. That's the milk with Carnation, water with Carnation. Then we test, here's the water with carnation. Look at that. It's up around 70%, but the milk, no. So remember, this is milk with carnation, 100% of the packet, water with 100% of the packet. So we keep going with the water. Again, this is 8 ounces of water with the whole packet. What happens? So the answer to the question is, did we need to keep feeding was no. Okay, our test, our probes, said to us, hey, we can go all the way up to 100% water with the whole package, and we can save ourselves a lot of time, which is really good. All right, so then what we start doing is we start replacing the water with milk. So now here, 10% of the glass is milk, and 90% is water, and 100% of the packet of carnation. Okay, so we've got the carnation in there. Okay, we got that done. And now we just have to switch the water to milk. All right, so we reverse. This is 100% of the milk with, 8 ounces of milk with the whole packet of carnation. Then we go to 20% of the glass is milk. And at first it looks like he's going to fail, but he recovers. We test the 100% milk with carnation, and he fails. And then 30% he does fine. Now, he was getting toward the end of his admission, so we put the mom in. Any kind of stimulus change, very typical. He says, nope, sorry, not going to do that. I mean, he didn't really say that. But he stops swallowing the 30% of the glass with milk, the whole package of carnation, and the water. So we put the therapist back in. Remember, go back to where you were successful. And so then we go back to the therapist. Then we put the mom back in, and he's drinking it. Now, remember, again, 30% of the glass is milk. The rest of it is water. 100% of the package of carnation instant breakfast. We test 100% of the glass with milk and carnation, and he swallows. And then we just keep going, and problem solved. Now he's taking a high-calorie beverage and getting a lot of calories, getting a lot of bang for his buck with that. Okay, so let's see. Let's do this one. This is a paper we published in 2011. Very similar situation. Again, child will take purees from a spoon, but he won't drink from a cup. This is actually the SPUP. So we tape the spoon to the cup. Now, this is percentage of drinks with mouth clean, and this is our baseline. Now, there's no data there. Does that mean we didn't take a baseline? No, I would never do that. No, you must have a baseline. No, the reason you don't have any data here is because the child didn't accept any drinks. And so in order to have mouth clean, you have to have accepted something. Something has to go in your mouth. And so that's why you're seeing that blank there. So when we presented the drinks in the baseline, the child didn't accept any. We started this intervention here, and here's the spoon. So this is, we're presenting the liquids on the spoon, and here we present the liquids on the cup. And what you see is there's a lot of variability. Clearly the cup is worse, meaning he swallows much less from the cup than he does with the spoon, but the spoon doesn't look all that great either, okay? What we think is happening is we think we're getting carryover, that actually the presentations of liquid in the cup are negatively impacting swallowing from the spoon. So we actually just go to all spoon sessions, and we just stop presenting the cup altogether. So remember, this is liquids from a cup, just the cup by itself. This is liquids on the spoon. That's the spoon by itself. And you can see, again, we're showing, yes, he will take liquids from the spoon. Remember, that's our starting point. We reverse back to baseline. That's just the cup. Again, no data because he won't accept it. So we want to replicate to make sure that it's a true, good finding. Again, this is liquids on the spoon, liquids in the cup. And you can see, again, a presentation of liquids on the spoon is better than presentation of liquids in a cup. But we don't want to feed him by spoon with liquids, right? We would like him to drink from a cup. So basically the same preparation you've seen before is this represents the distance from the cup lip to the spoon tip. And here are the data that we're using. Okay, so you can see that mouth clean is high at 3.8. That's right here. Again, we test. Will he take liquids just from the cup? No. So we move to 3.2. That's right here. He's swallowing at 3.2. Will he take liquids from the cup? No. So we move to 2.6. That's right here. He swallows at 2.6. Will he take liquids from the cup? No. So we go to 2.1, which is here. He swallows. Will he take liquids from the cup? No. So we go to 1.5, which is right here. And then we try the liquids in a cup again, and what happens? He swallows the liquids. This is just the cup. So after this point, after presenting liquids on the spoon with the spoon tip and the cup lip 1.5 centimeters from each other, we test the cup, and he swallows the liquids from the cup only, and there's 1 year follow-up. So again, the point is we want to think about what can we do as a starting point, and what kinds of changes, what kind of slow, systematic, and database changes can we make to get the child to do what we wanted the child to do. Okay, so one last graph, and then we'll show some videos that I hope will resonate or make sense to people that are not graphically oriented. So this is a paper that we published in 2013, actually with Caitlin's mentor, Melanie Bachmeyer. This is a child that would not swallow baby food, but would swallow juice in a cup. Now, you might be thinking, well, why are you getting kids to swallow juice? That's not very good. Or maybe you weren't thinking that. The reason that this is juice, but now you are, is because we wanted to equate the flavor of the solids and the liquids. And so this is apple juice and this is apple sauce. We didn't want there to be, again, any differences in responding based on the flavor of what we were presenting. We wanted to basically demonstrate that what we were going to do works, and then we can start adding foods of different flavors. So you can see the child, again, percentage of mouth clean. That's that product measure of swallowing. No swallowing with the baby food, but swallowing with the juice. And so what we do now is we start gradually fading in the food into the juice. So it's basically just getting thicker, or we're adding applesauce to the juice in these very complicated measurements. So why they look so complicated is because when we actually do the studies, and we shouldn't do this, is we use American measurements, like ounces and so forth. But when you publish, you have to translate them to metric, and so oftentimes they translate to these really like 59.16 mils measurements that are so crazy. Again, same basic paradigm. We're just gradually adding the applesauce to the apple juice, and then testing whether the child will take the applesauce as we fade. And again, just like in the previous studies, you can see here that acceptance or the swallowing for the applesauce alone is increasing in the probe. So it starts here at 0, 0, and then now it goes up to a pretty high levels here and here. And then finally, after this fade, this is 100% swallowing for the applesauce here and here. So let me just show you some videos that I hope will kind of illustrate the method. Okay, so this is a little guy comes to us, 3 years old, ASD, mom carries him everywhere. Anytime there's any changes in his environment, he has huge tantrum, falls, bangs his head. Really, he's actually a big kid for his age. I had him in the bathroom one day, and he started having a tantrum. We went to the floor, and I was trying to protect him. He bucked back and actually launched my body into the tiles, and I hit my head. I mean, he was really strong. No language, and gets his way by kind of tantruming and so forth. So this is mom trying to feed him in our baseline, which is a pretty standard thing that we do. So you can just get a feel for what goes on for her. I say this? He only drank his formula from a bottle. He had to drink Nutramigen. And he would only drink it if you gave him the bottle and he could lie down and do it himself. If you tried to change it in any way, he wouldn't take it. He'd drink water from a cup, but only one specific cup. One day he threw the cup and it broke, and Mom went and bought the same cup, but it was a different color, and he wouldn't drink it, and he ate Funyuns. Okay. I don't, they never do appeal to me. But anyway, he was very, very difficult to treat. And we tried a number of different things. Like I said, even when we would give him the bottle, so if we tried to present the bottle and let him hold it or change anything about it, he wouldn't take it at all. And so what we did was a fading procedure. We actually had to we tried starting with just touching a cup to the side of his face. This is how slowly we did things. So I'm going to show you a couple of sort of pieces of the fading process so you can just kind of see what it looks like in a kind of a real life context. Okay, but there's no sound. So how do I have to turn it? Like there's no sound icon. Will it come here? No. Can't do it in that. Yeah, I have to turn it off and on. Sorry.
Hi, this is Mason P. 219 2000.
Yeah, it's not. Dang. Okay, I'll just show you this one. What's that? All right, well, we'll just show this one. It's fine. Uh-oh. Sorry. I know. Bad news. Sorry, it's going to be like a few seconds. Maybe. Can you interrupt it with escape? No, won't. It makes it angry if I try to do anything. All right, maybe I'll take some questions so we don't waste time, because I'm a little suspicious of this thing. Oh, nope, wait. It looks like it might be doing something, maybe. I'm going to give it a second. I'm threatening it. Okay, all right, I'm going to take, no, ha. I knew it would do that if I threatened to take questions. All right, so let's go. All right, we'll just finish this out then. All right. Oh, but you can't even advance it. All right, you're going to have to watch this again. So you can see we had to put pads up because he bangs his head during the meal. And actually, you'll see later on, we'd let him use his iPad, but then he started clocking himself in the head with the iPad.
Together. Except for them, they're out of order, though. All right, drink.
So he's just touching the cup to the lip and just holding it there. That's it. That's all we're doing. And this is where we had to go back to the bottle because he didn't tolerate the cup over time. She's got the timer there because it's signaling.
Good job, Denise. Good job, Denise. Yay! Take it right. Good job, hitting your bite. Yeah, you can clap. Good job swallowing your bite.
chewing one? Oh, man. Sorry. All right, well, that's fine. There's another clip where he's chewing, but I think we kind of are running out of time. So let me just really quickly go over. So we started, you saw the one where she was touching the bottle to his cheek, and then we just gradually moved it over, and then we switched to a cup. And I don't know if you heard the mom, I don't think you could go to presenter view. It's going to go back to the beginning, so you have to present it. You have to show it like that. Okay. We presented a dry cup to his mouth, and then we actually dipped the cup in the formula and touched it to his mouth. And if you heard the mom counting, I don't know if you heard that. We actually started by counting 1 and holding it to his lip, then 2, then 3, until we went all the way up to 6. And then we actually just started tilting the cup. I mean, it was very, very slow. And then we had the liquid on the cup, which we touched to his lip, and gradually started depositing it. So it was very, very, very slow, a fading process, where we just systematically changed all the things that we were expecting of him. So I'm going to take questions now. Yes. So probably about, in that video that you saw, I would say about 9 months. And the problem was, it actually was a long time, because we had been feeding him for 3 months, 16 foods, and he started developing allergies, allergic reactions. So we had to take all of the foods out and then put them back in one at a time. And we got him eating 6 foods of the original 16. And then we tried to add some additional foods, and he started having reactions again. He's had a lot of, which I think illustrates that whole idea of, kind of medical workup. I mean, this kid was eating these foods for 3 months, and then all of a sudden started having problems. Yes. Oh, yep, sorry.
Oh, there you go. I'm pretty loud. I don't know if I need that. So when you started with him, I know you went with this formula, but you said he was only eating Funyuns, and then I noticed in the video you went to puree. How did you decide which puree you were going to pick first?
Good. So you heard which. I'm used to repeating the question. So our typical process, and this is just what we do, is when the child comes in for the admission, we have the parents select usually about 16 foods, 4 foods from each of the food groups, fruit, protein, starch, and veg, depending on the child's diet. So if the child eats all, carbs, we may not have the parent pick any carbs. So whatever we need to do to round out the child's diet in terms of calories and nutrients. So for him, it was 16 foods. But did you want to know how we started at puree texture?
No, I know how you started puree texture.
Okay, got it. You think? Yeah.
Did you just randomly, from those foods that they selected, you just picked so many of the purees, and that's what you were
No, we always, so in every session we present 4 foods, 1 from each food group, and we'll, over the course of days, rotate through all 16 foods. So we expose the child to those foods maybe several times a day. So breakfast, he'll have 1 set of 4 foods, lunch, another set of 4 foods, dinner, another set of 4 foods. But again, that's kind of how we do it, because these kids are in an intensive program. If you were in an outpatient program, you might select 4 foods that you work on, or 1 food. It just really depends on kind of what your resources are and what the goals are. But we rotate through them so that the child's exposed to all of those foods. So we start, just like Caitlin talked in the structure, we only present those 16 foods until we have acceptance and swallowing very well established. We train the family. Usually we spend the last week of our admission in the home, and then after the acceptance and swallowing is really well established, the parents doing the protocol correctly, and everything's going well, then we have the parents start introducing new foods and making changes to the recipe and so forth. Other questions?
Can you talk a little bit about what this looks like in a school setting, or have you had any experience of doing it in a school? I feel like OTs and speech, I don't see feeding at all.
Yeah. So in a school setting, obviously, you'd have to, make modifications in your goals and in your intensity. I'm not sure if that's what you mean in terms of what you're doing, but I think the structural part is similar. In other words, you can make some choices. So you could say, well, can we try to feed the child in the cafeteria, for example? and, maybe you're talking about initiating treatment or taking something like this and putting it into place in the school?
About putting it in place in the school.
Okay, yeah. So putting it in place in school. So the first thing is the kids that come to our program, or the kids that I showed you today, we're all in our day treatment program. So these are the kids with the most severe feeding problems. They have to have failed other treatments for at least 3 months before they can come in, or they have to have an emergent feeding problem. So these are the most difficult kids. We try to modify the protocol as much as we can to get it to be school friendly. So best case scenario would be the child can go into the cafeteria and, let's say, bring a lunch, and what they would just need to make sure is that at the end of lunch they put whatever's left back into the lunchbox so the parent can check to see if it was consumed or not. For some of the kids, we might ask them to have like a post-meal consequence. So if the child ate the lunch, there'd be some sort of, special thing like, he could 5 minutes extra recess, or whatever the school could offer as a reinforcer. For some of the more difficult kids, they're going to need somebody there with them, prompting and implementing contingencies. So it's going to really depend on the severity of the child's feeding problem when he leaves the program. And usually, most of the kids are going to require some level of intensity. So we have to work with the school to see how we can make that happen. Yeah. Well, what I would say to that is, to be educated, you have to be nourished, and you can't be educated if you aren't taking enough calories or the correct nutrients and so forth. So when we go to the IEPs, we really make a big push that this really needs to be a priority for the child to be appropriately educated, and also the structures that are controlling feeding are the same ones that are involved in speech, which is also very critical to education. So I think that there's a very good rationale for those kinds of goals to be included or incorporated into the child's IEP. Yes?
How do you alter your presentation if you find out the child is adverse or finds texture, smells adverse?
Would be basically sort of the same principle, is that sort of gradual introduction of, whatever the problematic, or starting with, for example, textures or smells that the child would accept, and then gradually fading in or incorporating ones that are more problematic. For texture, in terms of, you remember what Caitlin talked about, for lots of kids that come into our program because they are relatively inexperienced feeders, we often do start with the pureed textures. A lot of these kids just don't have the strength and stamina, even if they are chewing, to consume enough calories to gain weight and grow at the regular texture. And taking the texture down increases or decreases the effort associated with feeding. So if you're, going to put a teeny tiny amount of pureed food in the child's mouth, that's pretty simple, and it's pretty reasonable to expect that you could do that you could expect that the child would let you do that, or to set a limit that you're going to do it, and then gradually increasing the amount. And then we actually often teach the kids to chew. We find that unlike typically eating kids, we can't just simply raise the texture gradually and chewing skills will emerge. And so that's one of the things that I would check for, is does the child really, maybe that the child just doesn't have the skills to do or manage whatever textures the child is refusing. Oh, yeah, I can show you, if you want to see a quick, the next one, right? this one. Okay, I'll just show you a little bit of us teaching this guy. There's no sound. Oh, there we go.
Whoa, give it a shot, Mason. Quick. 92, I said 1, 2, 3. Good. Chewing. That was awesome. Even swallow. Yeah. Good. Swallow, Mason. Nice work.
Okay, so you can see this is like a kind of an intermediate point in our chew training. What he's doing is he's counting, because initially we teach kids just to chew rotely. Because oftentimes they're not able to grade the food, so they can't figure out, ooh, did I masticate it and is it ready to be swallowed? So we get it under instructional control, and then we gradually fade out all of those prompts. Oftentimes we start even before that. For kids who have no chewing skills at all, we use flexible airline tubing, and we'll cut it into strips and put a small piece of the food into the tubing so that the child can practice chewing in the presence of flavor, but without the risk of swallowing something that's not masticated. Other questions? Yes?
How would you start that with kids who can't imitate or follow directions or anything?
For chewing? So chewing is like a whole nother beast. But number one, this is really, really important. This child has to be under good instructional control. So that's why, again, why we often start with purees and get the child accepting a wide variety of flavors very readily, very quickly, allowing us to do things with the mouth, to look into the mouth, and so forth. So that's number one, which is critical. And then sometimes we'll start with just the bite in the tube, and we'll use 3-step prompting. So you can say, chew the bite, chew like this, and then if they don't, you can just guide. So you're just guiding one chew and switching sides and then shaping up that response and then going up to 2, 3, 4, and so on and so forth. But it's like a long, yeah.
When you say airline tubing, do you mean like that white clear refrigerator tubing?
Yeah, it's, or the ones that they use in aquariums. But you need to call the manufacturer and make sure that whatever you buy is safe for somebody to put in their mouth and chew on. Yep. I can show you, if we have a second, I'll pull up a picture for you. Other questions? Okay, so I'll show you, I'm just going to show you a little, couple concluding clips. This one. I like to just let you see the story of what happened to all these kids. Wait. Ooh. Do I need to just hit it? This one? This one. Got it.
Tell Dr. P what you ate today. We're going to send her a video. Yeah, look in the camera. Tell Dr. P what you ate.
Dr. P, guess what? I ate peas and Oreos and American.
Look here. Look.
And carrots.
Thanks so much. You've been terrific. I really appreciate it.
We can't thank you enough, Dr. Piazza and Caitlin, for coming to Pennsylvania and just, presenting such an informative session. So thank you again. Just a few reminders. Again, the poster session and the Art of Expression exhibit will be downstairs at 3:30 today in Dean's Hall 1 and 2. Also, if you are seeking social work CEUs, you must sign in and out daily at the registration desk. So today's code for this session is Z as in zebra, I, P as in Paul, 912. Again, the code is ZIP 912. Thank you so much and have a great afternoon.